Good afternoon, everyone. So this is a presentation that I really enjoy giving. It's about premium intraocular lenses, special situations, a current update. Now, when I say premium intraocular lenses, I mean any multifocal intraocular lenses, whether it is a trifocal intraocular lens or an EDOF lens. These premium intraocular lenses, there is a strong psychological barrier between implanting them for us on the physician side, not from the patient side. We do have patients that are very eager to have a trifocal intraocular lens inside their eyes, but we refrain from doing this for some bizarre reasons, actually, even if the patient is a very good candidate. So these are like extreme situations where I can show you that these premium intraocular lenses do work. But this is not the sort of the norm or the mainstream practice that we do. So the slides, yeah, okay. So what's the best candidate to start trifocal in? If you haven't done any trifocal intraocular lenses before, what is the candidate that you should hard sell the trifocal intraocular lens for? If the patient is immetrope or hypermetrope, of course. If he's dependent on two prescriptions, i.e. he does wear glasses for far as well. We see lots of patients who are +2 and they only want glasses for reading, but when you put them on the phoropter, they discover that with glasses for far they will be much better. These patients try not to hard sell trifocal intraocular lenses for, but if the patient knows that he needs glasses and he's dependent on two glasses, then go ahead and hard sell the trifocal. By saying hard sell the trifocal, I mean you are convincing the patient to get a service that he will really benefit from. If he is accepting to wear a weak reading glasses, if he's less than 1 diopter of astigmatism, if angle kappa is less than 250 microns, and if he is willing to do the other eye as soon as possible. And this is the patient that you should really try to convince to have a trifocal intraocular lens in. But what is the most challenging patient? What is the patient that you should really refrain from popping in a trifocal intraocular lens in? Patients with high, large angle kappa. Again, this is debatable now. Nowadays, we do not respect angle kappa the way that we did a few years ago. Patients with advancing cataract in one eye and the other eye is totally free. These patients usually get the benefit of the trifocal intraocular lenses in both eyes after they end up doing the other eye. So this might take up to 6 months or 1 year. Patients with large cylinder, of course, and large cylinder, I mean large expected post-operative cylinder, and patients who refuse to wear glasses at all. But these are the patients that we should counsel them, and I will tell you exactly how to counsel these patients. Now, angle kappa. Angle kappa has been on vogue for the past like 10 years or more. And of course, we started considering angle kappa, measuring angle kappa in hyperopic laser vision correction. And until Ammar Agarwal actually published a paper back in the day in 2011 saying that angle kappa really affects the results of trifocal intraocular lenses. Then came a plethora of papers by Steve Schallhorn, again saying that angle kappa is extremely important. It's one of the very important reasons why patients are not satisfied after you put a trifocal intraocular lens in, or a multifocal intraocular lens of any sort. And so people started to believe that angle kappa is very important, until this is the very first paper that made us notice angle kappa of Ammar Agarwal. But then came other papers that showed that patients with large angle kappa can be extremely satisfied after you put a trifocal intraocular lens. Actually, there was a paper that proved that in a large cohort of patients, angle kappa changes from the preoperative values to the post-operative values. So angle kappa is not like a solid thing that is written in stone. You can actually get different values preoperatively and postoperatively. So you should not really rely on angle kappa. And if a patient has large angle kappa, and by large angle kappa I mean not ginormous angle kappa, like less than 700 microns, it is pretty safe to implant a trifocal intraocular lens in. Again, these are the papers, so I'm trying to skim through the slides as quick as possible because we're really late in time. So what about a patient that had a previous corneal refractive surgery? I've been saying this again and again and again on podia. Classic teaching for any patient that had a previous LASIK, you should not implant a multifocal intraocular lens in, especially a trifocal intraocular lens in. I do beg to differ about this. What is special in LVC eyes? Today, this morning, we heard a very nice talk by Dr. Khalid on biometry post-laser refractive surgery. And the main problem after myopic LASIK is that all the machines sort of underestimates the central corneal refractive power. So it underestimates the corneal power, so you end up with an underestimation of the power of the intraocular lens that you're going to put inside the eye. So if you underestimate the power of the lens, you put the lens with the less power, you end up with a hyperopic surprise. This has been classically taught, but imagine that you do have this in a patient that has a monofocal intraocular lens. He will have hyperopia for far, severe hyperopia for intermediate distance, and a big amount of presbyopia, so will be totally blind or handicapped for near. So in these patients, if you put in a trifocal intraocular lens and you get the biometry wrong and you end up with a hyperopic surprise, at least the intermediate distance he can use in functional vision, not even for far, but for what we call the functional far, which is basically like 4 meters from his eye, and the near focus can be used in intermediate distance. So in the future, now I'm telling you this because we still up to this very moment, we do have like 10% of our patients. If you have a list of 10 patients, then one of them would have had a LASIK before. But these patients, most of the LASIK population had the LASIK done in the late 90s, early 2000s. So these are in their 40s now. They did not develop that much of cataract yet. So I think 10 years out, we'll have a tsunami of patients that had laser refractive surgery and are coming for cataracts. And in these patients, where there will be 80% of our patients, we really should know that putting in a trifocal intraocular lens is basically a safety net rather than a contraindication. Okay. Now the other taboo that was that angle kappa changes when you do a laser vision correction, and this actually proved to be wrong by a number of papers. So this is the question: would you recommend the trifocal intraocular lens for a patient that underwent LASIK? For me, yes. Yes, provided that he doesn't have a very high angle kappa and he has a regular cornea and he did a decent laser vision correction with a smooth cornea. Even if he has a small optical zone, it's a small central optical zone rather than a decentered optical zone, because a lot of these patients had their LASIK done back in the day in the late 90s, where we used broad beams and small optical zones. And we didn't have the watertight indications that we do have now. So we used to do LASIK for -12s and -13s. So these patients probably in now will have a sort of irregularity of the cornea. These are the patients that you should avoid putting a premium intraocular lens in. So this is one of the patients I always show this slide. I said on podia that you can implant a trifocal intraocular lens in patients that had LASIK. One of my colleagues did that, and the patient was extremely unhappy. He sent her to me and told me, "You told us to put a trifocal intraocular lens. You deal with the patient." So actually, when I saw this patient, it totally proved my point, because this is the eye that had a very high angle kappa, as you can see now down in red, and this eye, the patient was totally satisfied with it. But in the other eye, she had a smaller amount of angle kappa, as a decreased angle kappa, but she was extremely not satisfied. But if you take a look at the cornea, she had a bad cornea, a decentered cornea. So this is why these patients should really have a tomography and a topography. Make sure that the cornea is regular, but if it is regular, go ahead and implant a trifocal intraocular lens. Would you recommend a trifocal lens in the pediatric age group? This is a big question mark now, and my colleagues in the university, in the pediatric ophthalmology department or subspecialty, are doing a large study regarding this, because the thing is, when you implant a trifocal intraocular lens, you have 40% of the energy of the light directed at distance, and then you have 20% for intermediate, 20% for near. So is this distribution of light or decrease in the light energy amblyopia-genic or not? This is a big question mark. Would you use an EDOF lens better? Would you use a trifocal intraocular lens with much more weight for the intermediate focus or not? These again are unanswered questions till date. So, would you implant an intraocular lens in early documented keratoconus? The classic teaching is do not do that, and please do not try this at home. So do not, up till this very moment, do not implant a trifocal intraocular lens in a patient with keratoconus. But surprisingly, there has been a paper published from Tehran, in Iran, from Tehran, that reported good results in established keratoconics. So these are not patients with formed frosty keratoconus. These are not patients with corneas, keratoconus wannabes. These are established keratoconic patients that reported very good results after implanting trifocal intraocular lenses. So what about if you have a high corneal astigmatism? You should always differentiate between a patient that has high astigmatism preoperatively and a patient that will still have the high astigmatism postoperatively. In other words, if the patient has like 3 diopters of astigmatism and you do not have an access to a toric trifocal intraocular lens, then you cannot treat him, and you don't have a femto laser to do arcuate incisions, then you are pretty sure that the patient postoperatively will be 2 diopters of astigmatism, whatever you try to do with manipulation of your incisions. So these are the patients that should really avoid putting a trifocal intraocular lens in. But if you do have access to arcuate incisions, femto-arcuate incisions, if the patient has a little bit of astigmatism that you can tackle with the incisions, or if the patient, or if you have an access to toric trifocals, then definitely go ahead and do a trifocal intraocular lens. Again, this is a patient, this is one of the very early patients for a trifocal intraocular lenses with astigmatism when I started doing these patients. And this is the amount of astigmatism he had preoperatively. On the very second day, he, by just manipulation of the astigmatism, I do the double keratome incision exactly like my professor, Dr. Ali, is the way he said, and he ended up with a very, very good result, and the patient was extremely satisfied. If you do have access to toric trifocals, then go ahead and do them. They do very, very, very well. So I think in conclusion, premium intraocular lenses are gaining ground in cataract surgery. They are here to stay. They're not going anywhere. The associated visual inconveniences have decreased significantly. Even the halos that for myself, I counseled the patient a lot. I promised them that they will have halos postoperatively, but after surgery they told me, look, we do have halos, we see what you meant, but it's not a big deal. Patient selection is not rocket science. In our local market, a battery of choice has been available. Classic contraindications are being more and more challenged as new generation premium intraocular lenses are much more forgiving. I love the next slide, which is the most important 4 considerations in trifocal intraocular lenses. Number 1, keep the patient immetrope or a little bit slightly hypermetrope. And again, this is against our nature, our second nature when we're doing cataract surgery. Ever since we were residents, is to keep the patient on the low myopic side. If the patient ends up with a minus 0.5, minus 0.25, you're happy. Even if it's a minus 0.75, you're more happy. Now, this is something that you need to lose when you're trying to implant a trifocal intraocular lens. Always keep the patient on the plus side, on the plus 0.25 to plus 0.5 side. Actually, I've seen patients who are extremely annoyed for just being a little bit myope, minus 0.5. Again, what happens in these patients is that they see halos more for some bizarre, complicated optical reason. The halos are much more if the patient is a little bit on the myopic side. Avoid post-operative corneal astigmatism more than 1.5 diopters. Avoid angle kappa more than 0.7. Cover your patient with the Alcon trifocal intraocular lens counseling point. I've said this slide in industry meetings where who actually competed with Alcon, so I wasn't very popular. But the Alcon, you can always remember. So A is tell the patient that adaptation to the trifocal implant takes some time, like multifocal glasses. L, light glasses will be needed. C, there's no continuity of vision, so it's a trifocal with 3 foci, 1 for far, 1 for intermediate, and 1 for near, and he should expect that the intermediate vision between these foci will be in a little bit of a blur. We cannot promise the patient vision like he was 20 years old, emmetropia. And I always tell my patients that it's a compromise. It's as if you, God forbid, chop off your arm and you have all the money in the world, and you go and have a big lab to give you the most sophisticated advanced prosthesis. It will never be like your good old arm. O, the other eye should be done as soon as possible, and N, night halos are always present, but they are never too much and never handicapping. Thank you so much.